Hello, everyone. Welcome to the second virtual preceptorship in male infertility, the landscape of male infertility factors in ART. Good morning, good afternoon, or good evening, depending on where you are in the globe. I'm Sandro Esteves, and I'm very happy to be here with you today for the second live session organized by MEDEA, Medical Education Academy, and this time directly from the United States in North Carolina, Raleigh, in which the Dr. Calvert, Matt Calvert, I will introduce him later, will be hosting a very interesting session this morning. So just a brief information about MEDEA. MEDEA is a medical education academy providing, developing, implementing, evaluating medical education programs worldwide, offering support to healthcare professionals in continuing professional development with the final goal of delivering improved patient care. MEDEA has independent and international pool of scientific experts, educational experts, academics, and also leading healthcare professionals with long-standing background in different areas. And here you can see our therapeutic areas, including reproductive medicine. In reproductive medicine in particular, we have a board of experts that you can see in the screen. I believe many of them you know from different countries. The scientific director is Dr. Robert Fischer from Germany, and I'm very proud to be part of this board, specifically focusing on male reproductive health. So for this preceptorship, I have the great pleasure to share the meeting with Dr. Calvert. Matt is Director of Male Reproductive Medicine and Surgery at Atlantic Reproductive Medicine Specialists in Raleigh, North Carolina. He's also Adjunct Professor of Urology and Obstetrics and Gynecology at the University of North Carolina School of Medicine. Matt earned his MD with distinction, followed by urological residency at UNC, and he completed fellowship in male reproductive medicine and surgery at the Baylor College of Medicine in Texas. He has received grants from the NIH and SMSNA, the Doris Duke Foundation, and UNC Healthcare, and he has served as a co-investigator with the Reproductive Medicine Network of the NICHD. Dr. Calvert has published more than 75 peer-reviewed scientific articles and chapters. He currently serves on the board of directors for the American Urological Association Society for the Study of Male Reproduction and the ASRM Society for Male Reproduction and Urology. So I will handle the session over to Matt shortly, but before that, I would like to actually share some information about this preceptorship. As co-chairs in this program, we have Professor Alvigi from Italy, Dr. Fischer that I spoke about, and also Professor Peter Humayden from Denmark. Peter is going to be hosting the next live session I will speak about shortly. For this program, we are very happy that we have over 650 delegates from 66 countries, people with mixed profile, with lots of experience in male reproductive health and assisted reproductive technology, and several of them seeing a lot of patients per week. So this preceptorship has been accredited by the European Accreditation Council for Continuing Medical Education, and also the program has been submitted for accreditation to the CPD certification service in the UK. So there's more than live sessions in this preceptorship. We have the video lectures, we have videos of surgical procedures, videos of laboratory procedures, and obviously the live sessions, such as the one we will have just now. For you to get full advantage of this educational program, medeaacademy.com has a dedicated web page specifically for this program, in which you can go through all the video lectures and all the things that we prepared for you, including the contents of the first preceptor shaping male infertility that we had last year from May to June, in which, again, Dr. Calvert was chair of that meeting with me, and it was also a very successful program. We had several video talks, etc., that I invite you to check. So this is like the platform looks like. The educational materials are in medeaacademy.com, event Mayo 2022. You can see the video talks. You can see a library in which you have, the previous preceptorship contents, also videos of this program. And after the live session, the full session will be available for you to check also in the platform. This program, we have several partners endorsing the program. Very important contribution of the Algerian Society of Reproductive Medicine, the Brazilian Society of Assisted Reproduction, Brazilian Society of Human Reproduction, Brazilian Society of Urology, Spanish Fertility Society, the Italian Society of Fertility and Sterility, the Poseidon Group, the Portuguese Society of Reproductive Medicine, the Turkish Society of Reproductive Medicine, and the Tunisian Society of Gynecology and Obstetrics. Is a big thanks for all these societies supporting our program. So last week, we had a live session hosted by Androfer Fertility Clinic here in Campinas, Brazil. This session is already available on air. You can check the contents of that one. And on next week, on December the 10th, we will have a live session directly from Denmark of Skive Fertility Hospital, in which the session will be hosted by Professor Peter Humayden and his group. But today, we are for the second live session hosted by Atlantic Reproductive Medicine specialists, and this is what we will about to start. Please complete the post-webinar survey that you will receive by email to get your CME certificate of attendance, and also the diploma signed by the chairs. Just some important information: you can send instant message to other participants during the live using the chat, but please post your questions using the Q&A button that you see in the screen, and these questions will be answered at the end of each session. But during the meeting, you can post your questions anytime. Also, we will have some polling questions that will be presented after sessions and also during the case discussions. Please enter your answer, and the answers will be anonymized, and the results will be, collated electronically and will be displayed for us to understand what you think. So with that, I would like to hand over the session to Dr. Calvert. Welcome, Matt, to the program.
Thank you so much, Sandro. It's great to see you. It's great to see all of you out there, old colleagues and new all across the world. We're pleased to bring this program to you live this morning from Raleigh, North Carolina at our center, Atlantic Reproductive Medicine Specialists. And I should have some slides that should be coming up here shortly. Okay. All right, so this program is going to just be a welcome and introduction here to what we're going to do this morning. First, our faculty disclosures, which you can read here. And here's the agenda. Dr. Stevis has already given the welcome and preceptorship introduction, and I'm currently giving the welcome and faculty introductions for our center. And then we'll give a video tour of our center. Next, at 12:20, I'll give a summary of my video lecture, which I previously recorded. And then after that, we'll follow up with some polling questions. This will be a time where we'll interact with you at wherever you're coming in from on the webinar. We'll also have a discussion and question and answer, and I encourage any of you to send in questions that will help guide our discussion at that point. So that's at 12:50. Then we'll give you a video tour of our male infertility operating room here at 1:10, and then we'll have a clinical case discussion that I'll be joined by all of our faculty here at Atlantic Reproductive Medicine, and that will carry us out through the end of the preceptorship. So first, the faculty introductions. Our founder of Atlantic Reproductive Medicine Specialists, and she founded this with Dr. David Walmer. Our founder is Dr. Susanna Copeland. She's a reproductive endocrinologist who did her undergraduate training at Cornell, MD at Mayo Clinic School of Medicine, and then did residency in Pittsburgh, followed by a fellowship at Emory. She was on faculty at Duke before founding our practice here at Atlantic. Dr. Mary Peavy is another reproductive endocrinologist here at Atlantic. She did her undergraduate work at Duke University, followed by MD at University of Texas Southwestern, residency at Duke, and then fellowship in Texas at the Baylor College of Medicine. She was a member of the faculty at the University of North Carolina prior to joining Atlantic Reproductive Medicine a couple of years ago. Dr. Sushma Singh is our laboratory director here. She got her bachelor's degree in pharmacy at the Bombay College of Pharmacy in Mumbai. She has a PhD in neuroendocrinology from the University of Louisiana at Monroe, and did her postdoctoral fellowship and internship at West Virginia University and the Center for Reproductive Medicine. My name is Matt Coward. I'm a reproductive urologist. I did my undergraduate and medical training at UNC, residency in urology at UNC as well, and then a fellowship in male reproductive medicine and surgery at the Baylor College of Medicine in Houston, Texas. Dr. Stevis is a close friend of mine. Thank you for the invitation to co-chair this session with you. I have some written words that I'm going to read here in a second, but I do want to say that Sandro is someone that I've admired and looked up to since I was a trainee in urology. Long before he knew who I was, I knew who he was, read his papers, and he has led a very successful male infertility center in Brazil that's admired across the world. I feel very lucky to have done some academic work with him earlier. It was probably 2015 or 16. We did a book chapter together and got to know each other then, and have since become close friends. And so his bio is that he's the medical director of the Andrefort Clinic, a professor of urology at the Faculty of Medical Sciences of the University of Campinas in Brazil, an honorary professor of reproductive medicine at Aarhus University in Denmark. He is a board certified urologist specialized in male reproductive health and a consultant in reproductive medicine with over 25 years of clinical experience. He's built a solid clinical and research portfolio, designing and executing studies examining the relationship between male infertility and assisted reproductive technology outcomes and treatment protocols for infertile couples undergoing ART. Sandro holds leadership positions in the WHO Infertility Guideline Development Group and the Brazilian Society of Urology, Sao Paulo section. He serves as an associate editor of Andrology, Frontiers in Endocrinology, the International Brazilian Journal of Urology, and SIU Journal, and is an editorial board member of a dozen journals, including Nature Reviews Urology. Dr. Esteves is the author of 10 textbooks, and in fertility and reproductive medicine has published over 350 peer-reviewed scientific papers. His H-index is 66, and his citation count is over 13,000.
Thank you very much, Matt, for this very nice introduction. So this is a virtual meeting. We would love actually to make a face-to-face tour in the center and visiting the facilities and also meeting the team face-to-face. But since we are in a virtual preceptorship, I would like to take us for a tour in the clinic, if you don't mind.
Yeah, we would love to have you here as well. My colleagues and I have put together a nice little video tour that we're really proud to display this morning. Hope you enjoy. Atlantic Reproductive Medicine Specialists is the premier fertility clinic in North Carolina, situated on the eastern coast of the United States. Atlantic was founded in 2012 as a way to offer cutting-edge reproductive technologies in a highly personalized care setting. Located centrally in the Raleigh-Durham-Chapel Hill region, just a few miles from the Raleigh-Durham International Airport, Atlantic Reproductive Medicine Specialist is situated to serve patients from throughout the state of North Carolina, the southeastern region of the United States, and beyond. We offer individualized, comprehensive fertility care for both women and men, and we recognize and celebrate the diversity of all families. Couples, female patients, and male patients are all greeted by a welcoming front desk staff where they are treated like members of our own family. Patients are welcomed into our clinic in either the in-person setting or via virtual telehealth visits as is applicable to their care. The clinic is open daily, Monday through Friday, and on weekends as needed for treatment cycles. Patients and/or their support person or partners are welcomed. At Atlantic, our commitment is to support our mission of building families together. By providing both male and female fertility specialists in one clinical setting, patients and couples have a single medical home, allowing for faster and seamless care to address their fertility needs. Fertility treatments and journeys are tailored to each individual or couple's needs. Patients meet with their reproductive physician for initial hour-long in-person consultation, allowing for a comprehensive evaluation and review of treatment options. Female patients are served by 2 board-certified reproductive endocrinologists. Male patients are served by a board-certified reproductive urologist who is a full member of the fertility team and who performs consultations and procedures within the same facility. We provide a serene, spa-like environment for world-class reproductive care. At Atlantic Reproductive Medicine, the morning monitoring clinic allows for patients to efficiently undergo ultrasound and laboratory assessments of their IVF cycles daily or as clinically needed. A fertility provider performs the ultrasound, allowing for the interpretation of ultrasound findings in real time with the patients and help guide clinical care face-to-face during these visits. Our on-site phlebotomy team allows for patients to easily obtain blood draws as needed during their visit with same-day stat lab results available. The clinical setting also houses several on-site financial counselors, patient care coordinators, and a large, fully trained IVF nursing team.
In addition to the individual physician consultation rooms and offices, there are 4 dedicated ultrasound and procedural rooms. These fully equipped rooms allow for a variety of clinical services, including intrauterine insemination or IUI, full gynecology ultrasound, endometrial biopsy, no scalpel, no needle vasectomy, and 3D saline infusion sonogram. Male patients can undergo urological physical examinations as well as scrotal ultrasounds. At Atlantic Reproductive Medicine Specialists, the laboratory team uses state-of-the-art equipment to care for the sperm, eggs, and the embryos. A total of 7 microscopes are used, including microscopic equipment for gamete micromanipulation, embryo laser hatching, pre-implantation genetic testing for such as embryo biopsy, and sperm identification from surgical sperm extraction. The operating room on site is outfitted with a state-of-the-art Zeiss operating microscope for the most cutting-edge male fertility microsurgical procedures. Surgical procedures performed on site for male fertility patients include microtessie, tessie, MESA, electroejaculation, and many others. Vasectomy reversals and varicocele repairs are also offered by Atlantic Reproductive Medicine Specialists. The Atlantic Procedural Suite is designed with 4 pre- and post-procedural recovery suites. These procedural recovery suites provide space and privacy for family and patient support teams. Atlantic Reproductive Medicine offers a variety of procedures in office with anesthesia support as indicated. Hundreds of procedures are performed annually, including hysterosalpingogram or HSG, hysteroscopy, polypectomy or polyp removal, DNC, egg retrieval, and embryo transfer. Special space is dedicated to supportive measures during each patient's treatment journey. Atlantic Reproductive Medicine Specialists has reserved areas in which patients can undergo fertility-related adjuvant therapies, including acupuncture, immediately preceding and after their procedure in office. This on-site care reduces the stress and logistics of coordinating adjuvant visits. Atlantic Reproductive Medicine, building families together, one relationship at a time.
That's a great video, Matt. Thank you very much for sharing Atlantic Reproductive Medicine Specialists facilities with us. I am looking forward to visit you as soon as possible. My next visit to the region that I love, actually. This is a very beautiful place and love being there, visiting my son who is at UNC, as you know. So Matt has contributed tremendously to the male infertility preceptorship this year and last year. This year, Matt has developed a completely new talk on male reproductive anatomy and how it relates to sperm retrieval techniques. This is a very practical, lecture that you can see in the e-learning platform in full. Now, I would like to ask Matt to summarize the main aspects of this talk, which is so important for all clinicians working in our field.
Yeah, thanks again, Sandro. And we're just so proud of what we've been able to do in a short time. I didn't mention this earlier, but I had the first 9 years of my career at the University of North Carolina, where I'm still adjunct faculty, but made this transition just 3 months ago. And Atlantic has the best reputation in our region, the best doctors, the best staff, and the best outcomes. And I'm just so happy to be a part of this team. And so in a very, very short amount of time, we're able to develop a complete male fertility program and an operating room, which we'll give you a tour of shortly after this lecture, and already have a full running program where we've already done dozens of procedures here just in the first few months that I've joined this team. And so thank you to Dr. Copeland, Dr. Peavy, and Dr. Singh for bringing me here and allowing our practice to grow like this. So I hope you enjoyed that tour. So this talk is a summary of a lecture that I previously recorded. So it's about twice as long. If you want to see the more detailed version, which has been recorded on the Medea website. So this would be just a brief version, which will help set the stage for our live discussion later and help direct some of the material towards the polling questions and discussion that we'll have afterwards. The title of the lecture is Male Reproductive Anatomy and How It Relates to Sperm Retrieval Techniques. These are my disclosures. So the objective of this talk is to understand the rationale and the anatomy for why we as reproductive urologists perform certain types of sperm retrievals. There's a number of indications for sperm retrieval, but the main one is azoospermia or aspermia. So azoospermia is when there have been 2 semen samples that show no sperm after centrifugation. Aspermia is when there's no semen sample at all, where there's no ejaculate. Either of these conditions can be caused by obstruction, erectile or ejaculatory disorders, or spermatogenic failure. Obstruction would be about 1/3 of azoospermia would be from obstructive cases. And this can occur anywhere from the efferent ducts within the testicle all the way out to the urethral meatus. For erectile or ejaculatory disorders, this can result in aspermia more commonly, such as what we might see from retrograde ejaculation or neurogenic anejaculation. And then spermatogenic failure, which represents about 2/3 of cases of azoospermia. This can be either testicular or pretesticular, testicular being genetic etiologies. Idiopathic cases are most often testicular forms of spermatogenic failure, and these are treated with microtesy, and I'll go over that in this talk. The pretesticular causes of spermatogenic failure are essentially pituitary failure, Kallman syndrome, or congenital hypogonadotropic hypogonadism, as well as suppression of the pituitary by testosterone replacement or anabolic steroid use. And these pretesticular causes of spermatogenic failure are treated with typically gonadotropins, and I'm not going to talk about that. That's not something that you would do a sperm retrieval for. A separate indication for sperm retrieval would be high DNA fragmentation in the ejaculate with prior IVF failure. This is a huge area of interest of Dr. Esteves and his center, and hopefully you learned something about this at the previous live session. So I'm not going to focus a lot on this, but we do testicular sperm extraction when a patient does not have azoospermia or aspermia. So we want to go straight to the testicle for a case of high DNA fragmentation in the ejaculate. So I'd like to review the goals and considerations when considering sperm retrieval. So the goals are that we want the highest quality and the highest quantity of sperm with the least invasive approach as possible and with the lowest cost to the patient. The considerations that we take into account to achieve these goals include the training of the staff, the equipment available, the support staff. There are many timing considerations as to when to do the sperm retrieval as it relates to the IVF cycle, and then whether or not we would do the retrieval fresh versus frozen. The very most important consideration when considering a sperm retrieval are the patient factors. So here are some examples of the patient factors. I go into more detail on this in the longer version of this talk. But one is, does the patient have an obstruction? Does he have a delivery problem? Or is there a spermatogenic defect? And when a man has azoospermia, it's either a plumbing problem or it's a production problem. And so that's what I mean by obstruction or spermatogenic defect. And then with delivery, this would be things like erectile dysfunction and ejaculatory dysfunction. So if the patient is obstructed, again, this is about a third of cases of azoospermia. Where is the obstruction? And then where are we going to get the highest quality of sperm if the patient is obstructed? So less common, but a condition we see is ejaculatory duct obstruction. And we'll talk about this in the live case discussion. And a patient with ejaculatory duct obstruction may have the best sperm in their seminal vesicle. That's not common, but just an example. A patient with an inguinal obstruction, such as from a prior prostatectomy or obstruction from a bilateral inguinal hernia repair as an adult, might have the best sperm in their vas deferens, just proximal to the obstruction. And then patients who have epididymal obstruction, which is the most common type of obstruction that we see, are going to have their best sperm in the epididymis, and the options might be a MESA or a PESA, and we'll talk about what these mean later. If the issues with sperm delivery, can assistive ejaculation provide a sperm sample? If a patient has retrograde ejaculation, we would, and we weren't able to treat this successfully with medical therapy, those patients can have bladder sperm retrieval. And then patients with anejaculation, which is often neurogenic, but can also be psychogenic, those patients can be treated with electroejaculation to retrieve a semen sample. If the patient has non-obstructive azoospermia or a spermatogenic defect, we always go to the testicle. So always use testicular sperm. When it's a non-obstructive azoospermia, microtessi. When it's a case of high DNA fragmentation in the semen, you could do a TESI or a TESA. So where are the primary sites of obstruction? So you can be obstructed at the ejaculatory duct, in the inguinal vas deferens, in the scrotal vas deferens. The most common cause of a scrotal vas deferens obstruction would be a vasectomy. The most common cause of an inguinal vas deferens obstruction would be prior orchidopexy procedure, some sort of inguinal procedure, such as inguinal hernia repair, or a prostatectomy would obstruct the vas just up behind the prostate, and then the epididymis. So by the anatomy, this obstructive azoospermia can be all the way back into the seminiferous tubules. This would be a good example of this would be adrenal rest tumors, which we see in men who have a history of congenital adrenal hyperplasia. Next would be epididymal obstruction. This can be from prior surgery, prior infection, such as from chlamydia or STDs. Congenital epididymal obstruction is possible, and then spermatoceles can also obstruct the epididymis. The scrotal vas deferens could be obstructed through a vasectomy or congenital bilateral absence of the vas deferens, or CBAVD. Inguinal vas deferens would be a hernia repair, orchidopexy. The ejaculatory duct can be from different types of ejaculatory duct obstructions or from a stricture from prior trauma or infection. You can have obstruction within the urethra, and then even out past the penis in the foreskin, the phimosis, a condition called phimosis, where the foreskin can trap the semen even after it exits the penis. All right, so obstructive azoospermia can be either congenital or acquired. Congenital cases would be ejaculatory duct obstruction, CBAVD, or idiopathic epididymal obstruction. CBAVD can be from a CFTR mutation or disorder of Wolffian ductal development, which is commonly known as non-CFTR CBAVD. And then there's acquired cases. Acquired cases are somewhat less common except for vasectomy. Acquired cases of obstructive azoospermia can be from a urinary tract infection or a sexually transmitted infection. These can result in ejaculatory ductal obstruction, vasal obstruction, or epididymal obstruction. Trauma, iatrogenic acquired cases can be from prior instrumentation from urological procedures like kidney stone surgery. bilateral inguinal surgery like a hernia repair or prostatectomy. We're seeing more and more men who have had a prostatectomy as prostate cancer gets diagnosed earlier and earlier, and men are delaying fatherhood. So this is going to be a common and ongoing thing we'll see in our careers in future years. And then finally, vasectomy, which is the most common cause of acquired obstructive azoospermia. So this is a picture here of a patient with CBAVD here on the right side of the screen. Again, the common causes of epididymal obstruction are vasectomy, CBAVD, inflammation, and congenital epididymal obstruction. CBAVD is about 25 to 50% of men with obstruction have this. This is the most common cause of congenital obstruction, and it presents itself in about 1% of all infertile men. The two genetic causes are CFTR mutations, which comprise about 80% of cases of CBAVD. And then the second, which is about 20% of cases, are mutations in yet to be identified genes that are involved in Wolffian ductal development. And these cases are associated with renal anomalies. And so if a patient tests negative for CFTR mutations and they have a basal anomaly on one or both sides, they need a renal ultrasound, and we'll often find renal anomalies. Here in the picture on the right is demonstrating the portion of the epididymis which is not present in a patient with CBAVD, because this is the Wolffian structure here. So when a patient has CBAVD, we only have the very head of the epididymis where that number 2 and number 3 are. So it'll be a small nubbin of an epididymis, which is a small storage sac for high quality sperm. It's not always going to have high quality sperm there, but the patient will be constantly producing sperm through the testicle, moving it into the epididymal head there. And so we may find a higher quantity and motile sperm in the epididymis in a patient with CBAVD. So where can we get sperm during a sperm retrieval? So we can get it directly out of the testicle. That can be the default option. So if equipment or expertise is not available, this tends to be the easiest place to get sperm and the most reliable place to get sperm for really any of the conditions that we're discussing. It's not always the best. It's not always the highest quantity or highest quality sperm, but this is the default and kind of gold standard option. When a patient has epididymal obstruction from such thing as a CBAVD or a vasectomy, epididymal sperm tends to provide a very high quality and high quantity sperm sample. We can get sperm from the vas deferens. This is less common, although when patients have inguinal obstruction, such as from prior hernia surgery or prostatectomy, the vas can be delivered in a very simple technique that we use with no scalpel vasectomy. It can be hemitransected, and we can get a very nice sperm sample with a very minor procedure that doesn't even require even a single suture in the skin to get sperm from the vas in those cases. We can get sperm from the seminal vesicle when a patient has an ejaculatory duct obstruction. This is less common. Most of us tend to not do this very often, although this is possible, particularly in a pinch. And in most urology clinics, and general urologists are familiar with transrectal ultrasound and identifying the seminal vesicle. It's an easy structure to see on a transrectal ultrasound and easy structure to get a needle into to aspirate. When a patient has retrograde ejaculation, it's preferred to get motile sperm or high quantity of millions of sperm, and so we can get sperm from the bladder, and then of course we can get sperm from the semen. But if we could get it from the semen, we wouldn't be doing a sperm retrieval. However, if they have problems with erections or ejaculation, sperm can be extracted through assistive ejaculatory techniques. So sperm retrieval techniques for obstructive azoospermia is really alphabet soup. This is really hard to keep track of the four-letter acronyms that we use. These often get thrown around, TESI, TESA, and people aren't really sure what they're talking about. So I want to make sure that we go through these so you know that, because the letters actually mean different things depending on which technique we're talking about. So this is the simplest diagram that I can find on what these different techniques are. PESA up here in the top left, where you can see there's a percutaneous aspiration of the epididymis. And then MESA in the bottom left. Now this is an open aspiration of the epididymis. PESA stands for percutaneous epididymal sperm aspirate. The MESA stands for microsurgical epididymal sperm aspirate. So we use an operating microscope for a MESA. And then in the top right, we have a TESA. That stands for testicular sperm aspirate. And that's a percutaneous procedure. You see the butterfly needle there. And then TESI, which is an open testicular sperm extraction. So the top line here are the percutaneous approaches, and the bottom row are the open approaches. Looking at it a different way, the left-sided boxes are for epididymal sperm, and the right-sided boxes are for testicular sperm. So first, a TESA. So advantages for TESA is this can be done with just local anesthesia only. It could be performed at short notice. So if a patient was having trouble retrieving, if a patient was having trouble collecting a semen sample, for example, from anxiety, couldn't get an erection, and we've got the eggs are coming out, this would be the fastest and easiest way to get a sperm sample at short notice without anesthesia. And so I prefer the technique that's demonstrated here using a Kamiko pistol syringe, which is a simple device that allows you to put a vacuum suction on a 10 cc syringe. There's a lot of different techniques. It can be done with a butterfly needle. This is for some doctors the simplest and easiest approach to do for everybody, and I'm okay with that. But the disadvantage to doing a TESA is that you don't always get sperm. So the sperm retrieval rate's not 100% with this. You can have essentially a misfire where it's not done appropriately, or we don't get enough suction and you can't get the sperm out. We often do not get enough sperm to cryopreserve, so just a few tubules will usually come out. And so this is typically done fresh on the day of the egg retrieval. And when we do cases like this fresh on the day of egg retrieval, we do run the risk of not finding sperm and having to freeze the eggs. And so it has that disadvantage as well of not knowing the sperm quality until it's essentially too late. But this is a very effective technique for those who know how to do it, who do it frequently, and particularly in cases of obstruction, like a vasectomy, where someone has known paternity and there's really very little concern about this, the quality of the sperm. This can be a functional procedure. And then there's PESA, which is the percutaneous epididymal sperm aspirate. So these are the two percutaneous approaches. I don't do either of these very often. And that's just because we have the expertise, the staffing, and the equipment to do what I feel like provides a higher quantity and higher quality sperm samples. Although I think these are both excellent approaches. And for surgeons who know how to do these, who are good at these, they can typically get very high sperm retrieval rates. The PESA has a sperm retrieval rate that's only in the 90 to 95% range. And there's a bit of a higher risk of bleeding or hematoma because you can't really stop any bleeding. You have to stick that needle in there and fish it around with suction on it. But if you do hit the right tubule instantly in the first pass, that can be a very quick and easy way to get a high quality epididymal sperm, a sperm sample. And then there's the open sperm retrievals. So for surgeons that are comfortable to do this, these tend to only provide, another 1 or 2 days of recovery beyond what you might expect from a percutaneous approach. So it's really a negligible difference in the recovery. And these actually happen to be slightly lower risk because the bleeding, if we do see any, we are able to control it. So hematoma risks are generally lower with the open approaches. So a TESI is the gold standard. This is also known as a testicular biopsy. It can be done with local anesthesia only, but it can also be done with IV sedation. The sperm retrieval rate with the TESI is going to be the highest for obstructed cases. This is going to be approaching 100%. No special equipment is required for this. Almost any urologist can do this. It's a very simple procedure. Even if you don't have the fancy eyelid retractor that's pictured here, it's a simple procedure which you can make a slightly larger incision and deliver the testicle, which wouldn't be a big deal. The downside of this is that the recovery is a little bit longer, as I mentioned, from percutaneous approaches. Some patients are going to have, some surgeons are going to have concerns over epididymal sperm containing high DNA sperm fragmentation. I don't share that concern typically, although some studies suggest that that's the case, and if it's been tested for, then the testicular sperm would be ideal. But some people would prefer this over epididymal sperm in every case, and I think that's okay. In most situations, a TESI is the right call. The next one would be the MESA. This is a microsurgical epididymal sperm aspirate. This is the most complex of these procedures. So it requires more expertise. It certainly requires an operating microscope, which is not available in many centers in their operating room. But it's typically done with sedation, although it can be done awake. It has a very high sperm retrieval rate in obstructed patients. We get very high quality, high quantity sperm samples back with a MESA. Typically, I like the fact that with an open MESA, you can easily convert to a TESI, and we'll have a case where we demonstrate this later. These are some pictures of what a MESA would look like. I prefer just using a keyhole incision, which is the same incision for a TESI. The MESA is traditionally described with a full bilateral testicular delivery, which is really not necessary. We can get plenty of sperm from just one side, and we don't need to deliver the entire testicle. So we make about a 1.5 centimeter incision, put the eyelid retractor in just like you would for the TESI. We get testicular exposure, and then just rotate the epididymis into view, put a stay suture into it to secure it to the incision. And then we use an ophthalmic blade to make 1 or 2 or 3 little punctures, which allow us to sample different sites within the epididymis. So if we see a site that has very poor motility, we can move towards the head of the epididymis. And typically I'll check 3 or 4 sites. And this is something you can't do with a PESA, which you're just fishing the needle around in there and you can't tell where you're at. With a MESA, we're able to visualize the tubules. And you can see in that second picture on the upper right how those tubules look different, that there's the smaller white tubules and then there's those larger yellow tubules. And so we're able to look around and find the higher quality fluid, sometimes just under visual inspection like that. The average sperm retrieval rate we see with this is about 10 million motile sperm. And I only like a MESA when we're going to get about 30% motility. If the motility comes back very low, I like to pivot to a TESI, which would be through the same incision. All right, so for erectile dysfunction and ejaculatory dysfunction, these are the disorders of sperm delivery. So a patient might be aspermia or you know, in the case of a patient with severe erectile dysfunction, maybe unable to get an erection and unable to ejaculate. These would be sometimes older patients with organic erectile dysfunction. Maybe they've had a prior chemotherapy or radiation for some sort of pelvic malignancy. And then there's men with neurogenic erectile dysfunction as well from brain or spinal cord disorders. And men with retrograde ejaculation, this can occur with aging from enlarged prostate called BPH, or it can be a side effect of prostate medications, which help relax the prostate, but also cause the semen to move retrograde. And then the most common cause of retrograde ejaculation in young men that we see in the reproductive clinic would be diabetes. And I'm often diagnosing diabetes and type 1 diabetes in patients coming in with retrograde ejaculation. Surprisingly, this can sometimes be the primary and only symptom, a presenting symptom of diabetes. And then there's anejaculation. This is where men can't ejaculate. This can either be psychogenic. So some men have difficulty, just like the mental block with providing a semen sample for IVF, for example, or unable to ejaculate if they're not having intercourse. And then there's men with neurogenic anejaculation, which would be men with spinal cord injury, who almost always have some degree of severe anejaculation. So what if a patient can't produce a semen sample? This would be adolescents, patients with hormone abnormalities, nerve damage, spinal cord injury, emotional inability. Our options are going to be penile vibratory stimulation, electroejaculation, or sperm retrieval. And if we do a sperm retrieval, you really want to go straight to the testicle because these men are not obstructed. So you'd want a tessie. So the epididymis wouldn't really have a significant high quantity of sperm in it, and neither would the vas, since it's not really moving along when they're not ejaculating. So if they have spinal cord lesion above T10, so a high spinal cord lesion, penile vibratory stimulation is going to be the first line treatment. This is studied extensively in spinal cord patients, and we can just direct the patient to purchase this on their own and see if they're able to get a semen sample at home. And if so, they can then come in and collect a sample in the office. So this is simple, non-invasive, cost-effective. And for about 75% of patients with spinal cord injury, this is going to be successful. Some men can even proceed with at-home vaginal insemination using PVS. And then there's electroejaculation. So the only device on the market is a Seeger electroejaculator. This is a gold standard treatment for patients with neurogenic anejaculation that's refractory to penile vibratory stimulation. This is typically going to be required for patients with low spinal cord lesions, particularly like the common lumbar spinal cord lesion. And then when we do this procedure, nearly 100% will obtain an ejaculate, but it's a lot of non-motile sperm, typically, especially on the first one. And then if we are able to get a semen sample, 90% will have some motility. For non-obstructive azoospermia, we have typically it's going to be best to do a microtessie. This is the case that we'll be demonstrating in the video later. Using an operating microscope, the testis is bivalved and dilated seminiferous tubules are visualized for focally targeted excision. We see a higher sperm retrieval rate with this. It removes less tissue, preserves vasculature. And I really like this image with the blue arrow and the white arrow. You can see the white arrow has these little wispy white tubules, which are clearly less dilated than the ones with the black arrow. And this is the classic island of sperm that we're looking for in a microtessie. And that when you see something like this, that's a huge gift because it's not always that easy. But when we see that, that's where we typically would find sperm in that black arrow. So in conclusion, understanding male reproductive anatomy and etiology of the azoospermia or aspermia are critical to understanding and determining what the best sperm retrieval technique is going to be. From a patient with obstruction, any sperm source is really going to be effective. So this could be open or percutaneous, epididymal or testicular, fresh or frozen. So most etiologies of obstruction, anything will work. However, the most optimal samples really require planning and understanding of the anatomy. And so nuanced technical differences in these procedures can yield better samples. Men with sperm delivery disorders, erectile dysfunction, or ejaculatory disorders are good candidates for neurostimulatory methods such as penile vibratory stimulation or electroejaculation. And then lastly, men with non-obstructive azoospermia should be recommended always for microtesting. All right, thank you for following along the summary lecture of that talk. Again, if you want to see the longer version, it's been recorded online.
Thank you very much, Matt. It was a great summary. I think it clarified so many things. Now, the next part of our preceptorship today is fill up polling questions that I invite the attendees to respond, but also you can start posting your questions in the Q&A that you find in your screen. Please post your questions during the time we are actually addressing the polling questions. The question number one is like this. Which of the following sperm retrieval techniques performed fresh during an IVF cycle for a patient with a history of elective vasectomy will yield optimal sperm for IVF ICSI? Option A is, option B is TESA, option C is PESA, D, MESA, or E, each of the above would yield similar sperm for IVF ICSI. You can vote. We have 15 seconds for that. So here we can see the results, and I invite Dr. Calvert to comment.
Yeah, I love this, that we can see that people are all over the place with this, which really shows you that the answer is E, because any of these are going to yield equal results for IVF ICSI. You might get the most sperm and the highest quality sperm from a MESA, but that has the lowest number of responses, which is interesting. TESI is the gold standard for obstructive cases, so that shares the response number with PESA. But remember, TESI and TESA are essentially the same thing, and PESA and MESA are essentially the same thing. It's just whether you retrieve it with a needle or with an incision. And so, so the answer is E.
Thank you very much. Now we move to the second question. Which of the following sperm retrieval techniques would not be a good option for a patient with neurogenic and ejaculation from an incomplete L3 spinal cord injury? The options we have is like A, TESI, B, TESA, C, MESA, D, electroejaculation, or E. Each of the above would yield similar results for IVF ICSI for this patient. Please vote. interesting results. I will ask Dr. Caldwell to comment.
So the question is, which would not be a good option? And so some respondents who chose electroejaculation might have thought that the question said, which would be the best option? Because if that was the case, electroejaculation would be correct. When a patient has aspermia or has no fluid and they have a spinal cord injury, you're asking yourself, is this a production problem or a plumbing problem? And if it's a plumbing problem and they're obstructed, that's treated very differently than if it's a sperm delivery issue. So when there's a sperm delivery problem, you have two options. You can use assistive ejaculatory techniques, or you can go straight to testicular sperm. But epididymal sperm is never going to be a good option for a patient who does not have obstruction, that does not have epididymal obstruction, I should say. So the answer to this question would be C, MESA.
Perfect. Thank you very much, Matt.
Maybe I made this too hard.
I think the not, yeah, I should have emphasized it more. We go for question number 3, which relates to percutaneous and open sperm retrieval techniques. And it says, one primary disadvantage of using the percutaneous sperm retrieval techniques, such as TESA or PESA, as compared with open techniques such as TESI and MESA, is the following. A, percutaneous techniques require an operating microscope. B, percutaneous techniques do not always retrieve enough sperm for cryopreservation and therefore are typically required to be performed on the day of egg collection. C, percutaneous techniques have a significantly higher cost to the couple. D, percutaneous techniques have a significantly lower sperm retrieval rate. Or E, percutaneous techniques retrieve lower quality sperm. Please post your answers. This is the primary disadvantage. Okay.
All right, very good. So the majority answered this correctly, which was B. The techniques do not always retrieve enough sperm for cryopreservation, and therefore they're required to be performed on the day of the egg retrieval. So that's a disadvantage because logistically, for scheduling and for the couple having to have surgery on the same day, and the logistically for the reproductive urologist who may or may not have been available that day, this is a disadvantage to these percutaneous techniques. Sometimes we do get enough sperm for cryopreservation, but not always, and so that's the answer. Well, I thought this was a difficult question because some might say the answer is D, and that was our second most common choice. That and there is a lower sperm retrieval rate, but it's not really a significantly lower sperm retrieval rate. It's a slightly lower sperm retrieval rate. And in hands that are doing this regularly and routinely, it's probably pretty close to similar.
Thank you very much, Matt. Now we go for the last question, which relates to a case, clinical case. A 26-year-old patient has aspermia. Testing reveals retrograde ejaculation with 80 million sperm in the post-ejaculate urine sample. Further evaluation finds the retrograde ejaculation to be idiopathic and likely congenital. Treatment with symptomimetic oral agents, including pseudoephedrine, fails. And then what is the best approach in planning for ART? A, advised therapeutical donor sperm insemination. B, micro-TESE and subsequent IVF-EHC. C, PESA on the same day as the collection and IVF-EHC. D, alkalinize the urine and harvest sperm from the urine sample, cryopreserve some sperm prior to the cycle and plan for fresh sperm retrieval from the urine on the day of egg collection. Or E, diagnostic data for pathological analysis. You can vote, please. What is the best approach?
Very good. I thought this was a hard one as well, and this one had the most responses that were correct, which is to alkalinize the urine. And I thought that was difficult because I didn't go into any details on how to actually harvest sperm from the urine. But the point of this one is that the patient has 80 million sperm in the urine, which is a lot. That's a pretty normal sperm sample in the urine. So that's a time where you try to get that sperm harvested rather than put the patient through surgery.
Thank you very much, Matt. So I think now we can open the discussion, and please post your questions. We have some questions that I would like to have Dr. Coward's comments on it. One question relates to a practical one, I think, related to investing on electroejaculation device for clinics, I mean, around the world. Do you think actually it's worth going into that direction, or is there any, I mean, disadvantage of actually just staying with the sperm retrieval techniques that most people are familiar? And I would like you to comment a bit on that, and also related to psychogenic anejaculation, if these patients will need some sort of anesthesia for the procedure.
Sure. So when patient has normal sensation, they do need anesthesia. The spinal cord injured patients who have a complete lesion usually do not need anesthesia. I think it's worth it. The cost of an electroejaculator is about $15,000. And I'm sorry, I don't know the cost in all the different currencies out there who's watching this, but that's a similar approximate cost of one IVF cycle in the United States. The cost of that device is the same cost as one IVF cycle. And that device generally will pay for itself after just several uses, because when a patient has neurogenic anejaculation, they would rather have the option of providing a semen sample and not having to have surgery. So a spinal cord injured patient who has surgery is more likely to have a surgical complication such as an infection. And so it's a much lower risk procedure. We retrieve high quality semen samples typically, which can be banked and stored just like any other semen sample. And so it's a much lower risk to the patient. It's lower cost to the patient than a surgical sperm retrieval. And then as a center of excellence, to have the option to give that patient a center of excellence will receive more referrals from further away. Patients that might have gone to another center will now come to your center because you can offer a procedure that is not available, for hundreds of miles. And so the cost of the device, I think, is recovered by just several IVF cycles in a year. that you might do the procedure for. So I think it helps patients and it lowers costs for patients. It's easier and it's faster to do than a surgery, and it's a lower risk to the patient.
Thank you very much, Matt. There is a question from Dr. Musa asking, how are the seminiferous tubules dilated during a microTC? I mean, this is some sort of subjective evaluation by the reproductive urologist. I think this is a practical question for you. What do you actually see and how you make your judgment?
Well, at the last visit that Dr. Esteves had to our center, he brought me some very nice forceps, which I actually love to use for microTC, where the tip of the forceps actually approximates the size of a seminiferous tubule that contains sperm. I don't remember what it is. It's maybe 200 microns. Is that right, Sandro?
It's about 220, yeah.
220 microns is the tip of the forceps, which you can look at the tip of the forceps and kind of compare it to the size of the tubules you're looking at. The question of how it does this, you know, I don't know how or why. It's different every time. I mean, sometimes it's one tubule. Sometimes you can't find that one tubule, but they're dilated like islands within the testicle. And so there may be 5 or 6 sites within a testicle, 5 or 6 tubules that are dilated. You just have to find them by comparing the diameter of the tubule compared to the surrounding tubules.
Yeah, I find it very interesting to use the tip of the forceps like a ruler to try to identify. And also, you can send the specimen to the laboratory and ask the embryologist if they have, let's say, like most labs, they have the laser system in which you can measure actually the size of the tubule in the spring. And then you can also inform the surgeon about what kind of diameter, tubule diameter you have in that particular case that could also set the mind and also what the urologist doing the procedure is actually seeing. So there is a question from Sebastian Voinea. He's from Bucharest and asking if we have medical data that show that in a patient with ejaculatory duct obstruction, the sperm from the seminal vesicle would be better than the epididymal sperm.
I don't think so. And I use that as an example in my talk rather than a definitive measure. I would not prefer seminal vesicle sperm in a patient with ejaculatory duct obstruction. I would typically do a TESI for that. But do you have any comments on that, Sandro?
Well, I don't remember doing a seminal vesicle aspiration. I mean, in my career, I think we see some publications showing that it can be done. It seems not to be complicated, can be done in the office, but we also go for, we go for testicular sperm aspiration or, testicular sperm retrieval. We prefer not actually, like you said, not damaging the epididymis because, these patients have no obstruction. So in our hands, we found it easier to, just move to the testicle in these cases. And we don't have any experience to share supporting or, disagreeing with the quality of sperm obtained.
Well, I did this in fellowship at Baylor, and I did this as a junior attending for several years when I would see patients with those large dilated seminal vesicles on transrectal ultrasound just to stick the needle in, the same needle you would use to put the local anesthetic in for prostate biopsy. You just pop the needle into the seminal vesicle and pull back. And I would say once or twice out of 10 times, you'd get, 50, 100 million motile sperm, and it would look really good. And, you'd avoid the surgery and get a very nice sperm sample that you could bank. However, I've gone away from that. The majority of the time you get very, very high quantity of of debris and non-motile sperm, and I found that to be less useful than testicular sperm in general.
Thank you very much, Matt. We have a question from Dr. Rahayu from Indonesia. The question relates to, I think, the sperm that we get from a mesa. Basically is asking about, I mean, immature sperm, but and if we can go and use the sperm for ICSI, but I think perhaps, Matt, you can comment on the type of sperm that you find, and when you start more in the epididymis tail, in the body, or you just go to the epididymis head. What is kind of the practical approach that you use? And also you have very good experience with this office-based MESA that you published, and this seems very simple. And I mean, I would like also you to comment a little bit more on the practical issues of performing this operation.
It's a great question. Thank you for the question. Most of us understand that the sperm mature through the epididymis, and so as they come out of the testicle to the head of the epididymis, they're the least mature, and then as they move to the body of the epididymis and tail of the epididymis, they gain the ability for capacitation and increase in progressive motility. And so that's in a patient who's not obstructed. So the function of the epididymis in a male with normal reproductive function is that as the sperm move through, they gain maturity and they gain ability for progressive motility. However, when a patient has obstructive azoospermia from an epididymal obstruction, so CBAVD or vasectomy, the epididymis is going to be fully loaded with sperm, and the tail of the epididymis will have the lowest quality sperm, and you found higher quality sperm closer to the head. However, there's a point usually in the upper third of the epididymis where I find that you get the best progressive motility, and you're not coming right out of the efferent ducts. So it's usually somewhere in between the body and the head. So I usually start in the upper third. We sample 1 or 2 tubules, and if it comes back that the motility is 5% or less, I'll move more towards the head of the epididymis. But I like to find progressively motile sperm, which we believe are mature sperm and are function well with ICSI.
Thank you very much, Matt. I think we have time just for one last question that I will try to combine. Question from Dr. Oktarina and also Gerabi. Basically, they're asking for patients with non-obstructive azoospermia with high level of FSH, should we go straight to microtacy, and should we, or if there's any place for non-surgical, procedure, and how you choose the testicle, right, left, is there any, any characteristics that guide you for choosing the right or left?
Well, that's a great question. So when a patient has non-obstructive azoospermia and high FSH, I do tend to go straight to microtacy. We plan for a bilateral microtacy, but you can't do bilateral at the same time. So we always start with one testicle first. And I usually go to the larger testicle if there's one testicle that feels healthier. If they feel equal, I usually start with the right side, which tends to have healthier sperm just because of the high frequency of left-sided varicoceles. So I like to start with the right, and if we're successful, then we won't even do the left. And we can probably just move straight to the live cases from here, because that's one of the cases that we get into on our live case discussion.
So thank you very much. The questions that were left unanswered, we will provide the answers afterwards to all of you. Thanks a lot for posting your questions. And we have discussed a lot about sperm retrieval techniques, what we do in the operating theater. And I would love to ask Matt to give us a tour on what the operating theater looks like and actually what you do in that place. Could you please show us Atlantic Reproductive Medicine Specialist Operating Theater and your work in daily clinical practice, Matt?
Yeah, I really appreciate the opportunity to show you around here because Sandro has seen my previous practice and the operating room we had there. And so this is a brand new set of equipment. We've outfitted our operating theater with an operating microscope and other equipment and instrumentation. And so I would like to go ahead and play this video for you. Welcome to the new male infertility operating room here at Atlantic Reproductive.
Hi, this is Dr. Matt Coward from Atlantic Reproductive Medicine Specialist in Raleigh, North Carolina. I'm a reproductive urologist working within an IVF clinic, and this video is to demonstrate our brand new male infertility operating room setup here in our clinic. We use this operating room for office-based microsurgery, including sperm retrieval procedures such as microtesy, which is being demonstrated here in this video, MESA, or microsurgical epididymal sperm aspiration, TESI, or testicular sperm extraction, as well as electroejaculation. We have a Zeiss S88 Vario operating microscope and electrosurgical device for electrocautery. There's the anesthesia cart, which is used by our anesthesia team who administer monitored anesthesia care with a propofol infusion during the procedure. I have a fairly simple instrumentation setup here on a Mayo stand. The basics, as you can see here, are the local anesthesia, irrigation, scalpels, hemostats and Alice clamps, Adson and Bishop Harmon forceps, bipolar jewelers, and iris scissors. Here you can see the pass-through window from the operating room into the embryology laboratory through which the specimens are passed during the procedures. This is essentially the same instrumentation that I would use for a TESI, a MESA, or a microtesy. And then here's some footage from a recent microtesy procedure. Our andrologist is seen through the window awaiting the next sample. I'm scrubbed in here with my assistant. We've already got the exposure for the microtesy. During the dissection for a microtesy, I prefer using titanium Gerald forceps. As the dissection is proceeding, what we are looking for are dilated tubules to extract. Here's a plump tubule, which appears to possibly contain sperm based on the size of the tubule. Unfortunately, however, this patient did not have any sperm in any of the sites from which we extracted. When I have the sample ready, I pass it off to my assistant. We use small Eppendorf tubes, which contain 350 microliters of sperm wash medium, in which we place our sperm sample, which is then thoroughly minced with iris scissors before being passed off to andrology through the window, where it's processed for sperm identification. I typically take about 10 to 12 biopsies per side, and we map this out in a way that helps us to be sure that we've sampled most of the areas of the testicle. The mapping also helps us to go back to the areas where sperm is found so we can further search for additional tubules in the area of interest. Thank you so much for joining us on this tour of our male infertility operating room.
That's a great video. Thank you very much for showing us the infrastructure map. I find it very important to have the, you know, the operating theater just next door to the IVF lab, and also getting this, kind of immediate feedback from the laboratory on the quality of the specimen, etc. I know that some doctors, some centers, they do the operation in the hospital, and they actually transfer the specimens to the clinic, which perhaps is not the most optimal way, in particular, the most severe cases. So you actually set up the full, apparatus for the operations just next door to the IVF lab, which is great, having a fantastic microscope there. So do you believe that this is critical to have, let's say, the operations done in the same facility, or there are situations in which the hospital approach is equally valid?
It's such a good question, and it's difficult to answer because I know that what we have here is unique, and the reason that we're able to do it this way is because of the support that we have from our REI and embryology colleagues. Without that support, this would not be possible. Not just to outfit with the equipment, but really the space which is a shared space. That's the same room that they do the egg retrievals in. And so without that support, you know, I'd be doing this in the hospital, which is where I also do varicocele repairs. And so I have access to an operating microscope and an ambulatory surgery center. But you're right, Sandra, there's really no way to optimize your sperm retrieval when you don't have immediate feedback. Now, some surgeons have a small tabletop microscope in the operating room where they can mince the sample and look at it themselves. This tends to be very tedious, time consuming, and we're not trained as urologists to find sperm in the same way that the embryologist and andrologists do, who are really amazing at their jobs. And so oftentimes, I'm just amazed every time when they find the rare sperm that I don't think I would have seen if I had been looking myself. So it really takes a collaborative effort to be successful.
So if I can follow up quickly on that one, concerning logistics. You are using the same operating theater for the egg collections and the sperm retrievals. And then obviously in the workload sometimes make the sperm retrievals actually to be perhaps postponed to the afternoon, or you do it the day before. How actually you organize the schedule in the clinic? It's a busy practice, and this could be a very important practical information for all of us working with cases like that.
Well, we're blessed to have 2 rooms, and so we've run into times where we've had 2 things happening at once, and we've got a large pre-op and post-op area and 2 procedure rooms. So we have been able to have some spillover into our second room. But most of the time I'm doing the cases, we batch our cycles with up weeks and down weeks, and we do the sperm retrievals in times where we don't have a high number of other things going on in the lab. So for an IVF center that might be doing, 1,000 retrievals a year, you're going to need more than 1 room. And a larger lab and more staff, but we just happen to have the right size team and the right size space, and the way that we batch our IVF cycles allows for sperm retrievals to happen separately. Now, I tend to, and you can probably tell from the way I made the presentation earlier, we tend to cryopreserve most of the samples. So we do offer fresh sperm retrievals, although most of the time we're doing these on cases where we're able to cryopreserve the sample ahead of time. So the fresh sperm retrievals are reserved for cases that really need it. And we'll get into some of that during this live case discussion. So this live case discussion, I'm going to go ahead and bring in my colleagues, Dr. Singh, Dr. Copeland, and Dr. Peavy to join us as we go through these cases. Again, if it's not clear, I'm so happy and proud of our team in a very short amount of time that I've been with this practice in the last 3 months. These are all cases that we've done here together in the last 3 months. So we've done a number of sperm retrievals already, taking care of some complex patients. And so you're going to see on the outcomes that, you know, we have ongoing pregnancies, not live births, because these are all very, very new cases. So our first case is a 37-year-old male who has a 28-year-old female partner who's G0. He has primary infertility for 18 months. He's healthy with no past medical history or past surgical history, takes no medicines, and had 2 semen analyses, both with low volume azoospermia. So his testicles were normal volume, 17 cc's. They were symmetric. He had no varicocele, but he had no vas deferens palpable bilaterally. So that's a physical exam finding. That's not something you can get on an ultrasound. So this patient has a CBAVD by his physical exam. He had an epididymal head, which was indurated bilaterally. That means it's just firm, and you can tell that it was full of sperm. He had a left epididymal cyst. His hormone evaluation found that he had normal gonadotropins, a slightly low testosterone, which is common in this condition. He had a CFTR screen where he was found to be heterozygous for delta F508 mutation. Interestingly, he was negative for 5T. So most men who have CBAVD carry the 5T allele along with a pathogenic CFTR mutation, but he was only heterozygous for delta F508. So his diagnosis is obstructive azoospermia, secondary CBAVD from a CFTR mutation. Do we have time for the polling questions, do you think, Sandro, or should I just go through the answer?
No, we are on time.
Okay. So this is a polling question. What method of sperm retrieval would you recommend for this patient? Remember, he has obstructive azoospermia and has a CBAVD. And it's, okay, there it comes. All right. I've already sort of asked this question once before, so we'll see what people answer now. Do I advance through this, or does this automatically come up with the answer?
It will come up.
Okay. Wow. Okay. So microtesty is the most common answer here. Just to go back to the original talk, when a patient has obstruction, microtesty is not the right answer. That's only going to be what you want to do when someone has non-obstructive azoospermia. So any of the other answers would have been accurate for this case. I prefer a MESA, but TESI, TESA, or PESA would be totally reasonable and accurate. So when I do a MESA, we consent for possible TESI. And that way, if I don't like the epididymal sperm, we can get testicular sperm. And I talk to patients about that ahead of time. So this case was planned for a MESA possible TESI. And I should also mention some data that we published a few years ago from patients with CFTR mutations, found that about 80% of the time, a MESA is all that you need, but about 20% of the time, you do need a TESI. So you need to be either prepared for both, and if you're not prepared for both, just go straight for testicular sperm. We started with the right-sided MESA. The epididymal fluid proved to have very poor quality, very low quantity. Only rare sperm were observed. Mostly debris was seen. And so we quickly pivoted to the TESI. The TESI sample came back completely normal with 2 to 3 motile sperm per high-powered field. So then we moved on to IVF using the TESI sperm. She had 12 mature eggs retrieved. We had a 50% FERT rate with ICSI, 6 of 12 fertilized, had 3 high-quality blasts, We did not do PGTA because of her age was only 28. They had a recent FET of 1 blast. And actually, as of yesterday, this couple has a positive beta, so she's pregnant currently. And that FET was just a couple of weeks ago, obviously. We'll open this up to discussion at this point with our faculty.
Dr. Coward, great presentation. I do have a question here. Would you, in this case, since it was an obstructive case, would you have preferred a PESA or a TESA as opposed to a MESA to start with?
Yeah, I mean, this gets back to the classic percutaneous versus open question. When a patient's obstructed, any of those are options. You know, I like the MESA TESI versus, you know, more, I like that more than the percutaneous approach, because the percutaneous approach really needs to be done on the day of egg retrieval. And so what this allows us to do is to identify the quality of the sperm. We can get a test thaw. Sometimes we get a MESA and a TESI, and we can see which one we like better in a situation like this. So there's a little bit more versatility with the open techniques. However, the downside is you have to have the equipment, you have to have the expertise, you have to have the room, you have to have the lab staff helping you. So I recognize that that's not always available. And so many centers will have a urologist come in on the morning of the egg retrieval and do a quick percutaneous approach, which is a very reasonable approach for a case like this.
And to follow up on that, question as well, Dr. Singh, do you, if all things are equal, would you prefer epididymal versus testicular sperm from a lab perspective?
From a lab perspective, when you're trying to retrieve sperm to do the ICSI, it really helps to have the epididymal sperm as opposed to the TESI sperm. Just a lot easier to work with. The processing and just the amount of debris is very minimal in an epididymal sample.
How would you feel about doing Zymo for epididymal sperm? If you had a really nice epididymal sperm with 10 or 20 million total modal count, high progressively modal sperm, would you consider processing it through microfluidics, Dr. Singh?
Yes, definitely. In fact, that would be great if you can get a sample with really with good motility and forward progression, because that would eliminate centrifugation. So really would improve the processing method.
I think that that comment perhaps goes well with one of the questions we have from the attendees. This is Dr. Shlomi Barak from Israel. Thank you very much for being with us. He is complimenting, obviously, for the great presentation, but his concern of the MESA specimens that, according to his experience, perhaps increases the recurrent pregnancy loss, or you have more miscarriages, especially considering that in some cases, the sperm DNA fragmentation could be higher compared to testicular sperm. And he's also sharing his experience with that, saying that in some cases, the testicular sperm in his hands is providing better results, and what kind of thinking you have about that.
That's a nice preview for case number 2. So I'd like to table that, and we can talk about DNA fragmentation on epididymal and testicular sperm with the next case, if that's okay.
Absolutely.
Dr. Coward, number one, as we have presented these cases, a beautiful presentation. I just want to say how grateful we are that you have joined our practice, because what you've done in a very short period of time has really been remarkable. And thank you for helping provide this care for our patients. But with regards to MESA and TESI, that does allow us to cryopreserve the sample ahead of the IVF cycle. And then we have known quantity, known quality of sperm. Could you review the scenarios where you are going to preferentially talk about a fresh MESA or a TESI with a patient?
Yeah, so thanks. That's a great question. So fresh Tessie or Mesa is going to be a secondary option in my mind as we consider a patient who's obstructed. So someone who has previously failed a sperm retrieval where there was very poor quality sperm. Maybe it didn't freeze and thaw well. Maybe we had enough to freeze, but then the test thaw looked very abnormal, or there was no motility on the test thaw. That might be someone who we kind of hold off on the IVF cycle until we can set them up for a fresh sperm retrieval. I'd rather do 2 sperm retrievals than 1 failed IVF cycle. And so if that's a scenario where we can avoid a failed IVF cycle because we're not using a really poor quality frozen sample, that's a time when we would do it. We would do it for someone with prior failed IVF with ejaculated sperm, where we're trying to get a better quality sperm as far as the DNA fragmentation is concerned. I think fresh testicular sperm is probably going to be the highest quality sperm from a DNA fragmentation standpoint as well. And then the last point here about the importance of CFTR testing for a female partner. This can be to either Dr. Copeland or Dr. Peavy. So when a male patient with CBAVD is found to have a CF mutation, we usually recommend that the female partners test it as well. Would you recommend genetic counseling for these couples? And then as a follow-up to that, how would you feel about doing PGTM for CFTR mutations or PGTA, where we only transfer a female embryo in order to not transmit the heterozygous CFTR mutation to male offspring, which we know might result in symptomatic azoospermia?
I think that's a really good point that you bring up, Dr. Coward, about the overall counseling this couple has, even as they're making treatment decisions. Definitely would recommend that they meet with a genetic counselor and have a long discussion about the implications of his carriership, but also on any children that they have with his possible genetics as well too. So that would definitely be strongly recommended and encouraged for couples to undergo that ahead of time. That can probably help them navigate their decisions in terms of the questions you pose for PGTM or maybe gender selection to avoid reproductive risks with this allele that they have. So it would be a very complicated, thoughtful question for the couple. I don't think there's a full right or wrong answer on their decision tree for that. But if Dr. Copeland, if you have additional thoughts, I'd love to hear.
No, I agree with how that was stated. And I think the dilemma with, of course, if the female partner is found to be a carrier as well, then that's definitely a discussion about PGTM. But in prior patients I've referred for this discussion, what I've received back from the genetic counselors is that it's difficult to predict phenotype. And when it's difficult to take the genotype and predict the phenotype definitively for the child conceived, they're less likely to recommend the PGTM. But this is an ongoing discussion that is the importance of making sure that these couples have genetics counseling.
Thanks. That was a great discussion, y'all. All right, so we'll go on to the next case. So this is a 71-year-old male. He's got a 40-year-old G0 female partner. He has proven paternity with 4 grown children and had an elective vasectomy 30 years ago. This is a healthy, very spry 71-year-old male with no significant or contributory medical or surgical history. Testicular volume was normal, symmetric, no varicocele, palpable vasectomy in the mid-vas bilaterally, moderate epididymal fullness bilaterally. His labs came back with a normal total testosterone and normal gonadotropins, consistent with normal spermatogenesis. So his diagnosis is relatively simple because we know he had an elective vasectomy. So he has obstructive azoospermia secondary to vasectomy, although the complicating factors here are that the vasectomy interval was 30 years ago, 30 years interval, and he's got very advanced paternal age. All right, so another polling question. what method of sperm retrieval would you recommend for a patient with vasectomy? And actually, I'm just going to go and just so to save a little bit of time. Again, the A, B, C, and E would all be correct. It's probably whoever's doing PESA is answering PESA every time, and whoever's doing TESI is answering TESI every time. But you don't want to do a micro TESI in a patient with obstruction. So any open or percutaneous approach would be fine. What we tend to do is, again, a MESA or a TESI, or I should say the open procedures. That gives us the most versatility for cryopreservation. And in this case, we also plan to do DNA fragmentation testing on the epididymal sperm. So my plan was to do both MESA and a TESI. So on the MESA, I was surprised to find this on this result, but we got very high quality and high quantity epididymal sperm. We had 27 million total motile sperm that was banked into 5 vials plus an additional vial for sperm DNA fragmentation testing. His TESI also came back normal, and this was banked into 4 vials. DNA fragmentation on the MESA sample came back at 16%. So normal would be under 20%, borderline would be 20 to 30%, and over 30% would be abnormal based on the test that we use. And so this would be a normal DNA fragmentation on the MESA sample, which was surprisingly excellent quality and excellent quantity. So based on that, we decided to do IVF using the MESA sperm rather than the TESI sperm. Again, to what Dr. Singh mentioned earlier, it's easier for the lab to work with and to find progressively motile and normal morphology sperm. So she had a great IVF cycle. She had 9 mature eggs retrieved. We had a great fertilization rate of 67%, 4 high quality blasts. She underwent PGTA because she was 40 years of age. And we had 2 euploid embryos. So an outstanding IVF cycle for this couple. And she just had her transfer of a euploid embryo last week. All right, so we're going to open up the discussion for case number 2 on a patient with vasectomy and advanced paternal age.
Thank you, Dr. Kai, for bringing up this case because I think it poses a lot of very interesting clinical questions. What I have for you sort of from the REI perspective is that sometimes these patients come see REI first before they might see you. And so in these cases, they might ask if, a vasectomy reversal is even an option or a feasible option if it's been 30 years since the original vasectomy. What are things that you would bring up with this patient about those options if they had asked if that could be performed?
Yeah, I mean, the question of can we or should we kind of comes into play. We certainly can do a vasectomy reversal for a patient with any vasectomy interval. We see as vasectomy reversal outcomes kind of goes up, I should go this way, goes up and then levels out. So our success as far as the vasectomy interval goes, I should say goes down and levels out because as the interval increases, we see a declining success, but it never really declines below about 40%. So a case like this with the sperm quality, seeing what it was on the MESA, he probably would have had a successful vasectomy reversal. Even if he required epididymal vasostomy, which is likely. However, you have to take into account the female partner and her age and her timeline. If she was 28 years old and they had a very long horizon, that might be very reasonable to do a vasectomy reversal and a TESI. And that way you cover both bases. You get the sperm retrieved in case you have a failed reversal, but you also give them a chance to conceive over the next year or two as they kind of plan for their next steps. But in this case, this couple came to me actually referred by Dr. Walmer in our practice as just someone who was ready for IVF. I wanted to move to the next discussion point, and this one is for you, Sandro. So the patient's 71 years of age. what sort of risk would you discuss with a patient like this as far as risk to the for advanced paternal age?
I think it's a very important point because we have data now showing that advanced paternal age is related to increased risk of chromosomal abnormalities like advanced female age. So there's nothing we can do about that rather than actually offer PGTA for a patient like him, for the couple, I mean, to try to avoid, I mean, risk of having a child with some congenital disability. I don't know if actually the DNA fragmentation on the testicle will be increased in the epididymis. You showed very, I mean, good results for the specimen you took from the epididymis. In our experience, I'm not talking about age now, but I'm talking about overall cases in which we do approach like MESA, and at the same time we take a TESI specimen, and then we do sperm DNA fragmentation analysis on both, and we freeze, and then we go for, because in the obstructive case, I mean, freezing goes very well, and then we decide based on the sperm DNA fragmentation results which specimen to use for ICSI. But for advanced paternal age, I definitely would discuss and recommend PGTA.
You're really a pioneer in this area, Sandro, and I think the idea that I had for this case, and which I've been doing since we've known each other, and even considering this, is based on the data that you and I have discussed, that and the way you do things in your center. Now you get DNA fragmentation a little bit more easily. We mail ours out and intend to be doing this in our lab sometime soon, but that's been lower on the priority list as far as getting our practice set up for all of this. But I would like to be able to offer that the way that you do it in the future. But in a case like this, where the TESI and the MESA are being frozen, we can send out epididymal sperm for DNA fragmentation. I've got a question for Dr. Peavy about advanced paternal age. So the ASRM male infertility guidelines came out at the end of 2020, and guideline statement 7. So it's very early in the guideline. It's actually, there's many guideline statements in this long guidelines. Statement 7 is that clinicians should advise couples with advanced paternal age greater than 40 that there's an increased risk of adverse health outcomes for the offspring. And this guideline is really written for REs. And I think reproductive urologists generally are expected to know this stuff. And so we're going to talk about it in our consults. But do you think that there might be a missed opportunity here in the counseling of couples where the male partner is greater than 40?
Yeah, I think that's a great question. I'm glad that it's been really highlighted in recent recommendations, because I think historically there's been a lot of focus on the female partner age and how that affects outcomes and paths going forward. So I think when we think of age, it's historically been much more focused on the female, whereas, as you brought up, it's actually very important to be focused on the male. So I think it's an area that can be continued and should be continued to be discussed more in those consultations with couples together. Often, if a gentleman is above the age of 40, his female partner might also be near or close to more advanced age too. So sometimes it gets overlooked on the male part. And it's a great point that they bring up and to be continued to be talked about during visits. Yeah.
Thanks for those comments. I know we had prepared other things to discuss, but we're only halfway through this presentation, and I'm worried we're not going to get to our 4th case. So I'm just going to move forward with case number 3. This is a very interesting one. And if we end on this case, that's okay. 41-year-old male has a 40-year-old G0 female partner, primary infertility for 4 years. He has sexual dysfunction. So he's got a normal climax, but his ejaculatory volume has decreased since he was younger. He's not really sure when, but he denies symptoms of retrograde ejaculation. So no cloudy urine after ejaculating, no dripping of semen after ejaculating. He denies lower urinary tract symptoms, and he reports low libido and erectile dysfunction for the past 3 to 4 years. Interestingly, he relates some of these problems to a groin strain that he had in 2019, where he had lower abdominal pain and scrotal pain. He's got a lot of anxiety about this, as well about the fertility, but also about this pain that he's had. He's started duloxetine for the pain, but otherwise his medical and surgical history is non-contributory, and he's got no significant exposures. His exam demonstrated exceptionally normal testicular volume, 26 cc's bilaterally. He had subtle grade 1 varicoceles palpable bilaterally, no inguinal hernias or any explanation for this pain that he had. So his semen analyses are kind of interesting to go through here. He had 7, and the reason that he had so many semen analyses is because he was getting all these different results, and we were trying to figure out what was going on. His very first semen analysis was low volume, but showed normal concentration and normal motility and a reasonable total motile count. That proved to be an outlier. Again, remember, this couple had 4 years of primary infertility. The next sample showed normal volume, 1.7, but low concentration and only 1% motility. When you see motility that's only 1%, that's suggestive of obstruction. Then we, on a subsequent sample, very low volume, 0% motile. We then obtained a post-ejaculate urine, again, low volume, better concentration, still low motility, and the retrograde proportion was only 17%, which is not generally considered to be clinically significant retrograde ejaculation. That was repeated, and no sperm in the urine the second time that we did that. So the semen analyses have really been all over the place, but ultimately he was able to provide several samples for sperm banking, and we're able to collect ejaculated sperm and freeze it. His labs came back all normal, so suggesting normal spermatogenesis. Again, normal testosterone, normal FSH. He was tested for CFTR mutations, which was negative. And when men have ejaculatory problems, I'd like to check for diabetes, and that was normal. I'm going to move past that polling question and go ahead and tell you that my working diagnosis for this patient was a partial ejaculatory duct obstruction. The first IVF cycle we did with the ejaculated sperm sample was a poor semen quality, but there was enough motile sperm for every egg. She had 8 eggs retrieved. Fertilization rate was 50%. Only got 1 blast, which was abnormal, so failed IVF. So at that point, we planned for a TESI and then repeat IVF. The TESI came back really normal, exceptionally normal, froze 5 vials. Test thaw had motile sperm. And so then we did a second IVF cycle using the frozen TESI sperm. You could argue to do a fresh TESI in this scenario. I mentioned that earlier. This would be a case you could do a fresh TESI. But when you have 26 cc testis and normal semen, normal gonadotropins, you fully expect this to be normal, which it was. So the second IVF cycle, we had a completely different result, 7 out of 10 FERT, 3 high quality blasts, and she is currently pregnant after transfer of a euploid embryo. So this is a complex case of male factor. There's several things that we can discuss here, but my first question is that, this is not a confirmed diagnosis. And so for Sandro, would you agree with this diagnosis, and would you do further workup? Because we talked about, cysto and imaging and other things. ultimately they were eager to pursue IVF using either ejaculated or testicular sperm, and so the further workup was not undergone for those reasons. But what do you think about this is going on here?
Well, it is a very interesting case, and I think the patient has some sort of ejaculatory dysfunction, most probably partial ejaculatory duct obstruction. I think it's a good diagnosis that you made. We had cases similar than that, and although we can go further with the investigation, doing transrectal ultrasound, perhaps even seminal vesicle aspiration, we need to consider the couple and age, in which the female age is now 40. And I mean, this is something that we need to put into the equation. So I would try to go more in a pragmatic way, like you did. And I would definitely go for the testicular specimen in this case, based on the experience we had with lower DNA fragmentation, and the results are quite satisfactory. So yeah, would be my comments on that.
I have a question for you, Dr. Coward. I think this is a great example of how not all sperm are created equal. We saw with two different sources of sperm, we saw completely different outcomes with the IVF. The birth rate was different. The fact that we had euploid embryo, great blast development with the tessie. What do you think caused the sperm to be so different or so abnormal with the ejaculated versus the testicular sperm?
Well, with the presumptive diagnosis of partial ejaculatory duct obstruction, these are sperm that are barely squeaking out, and I think of them as like the tired sperm at the end of the marathon. And so they've taken a longer time to be ejaculated. They've barely gotten out. The ones that are moving are probably just twitching, and they've been exposed to whatever reactive oxygen species or environment is going on for longer because of the obstruction. So they're not getting out in an equal time. And so what that does is it increases the DNA fragmentation within the sperm, so that ejaculated sperm, although it was not tested here, probably had a very high DNA fragmentation rate. And so the difference here is dramatic. What you can see in testicular sperm versus ejaculated sperm, because this is very different than someone who has non-obstructive cryptospermia, where the sperm are getting out, they're not obstructed. Those may not have high DNA fragmentation, and rare sperm might have an equal fertilization rate as testicular sperm in a case of non-obstructive cryptospermia from sort of on the spectrum of testicular failure. That's not what this patient had, and this is why you see a very different result with testicular versus ejaculated sperm. Any comments on that, Sandra? I know you have a lot of experience in this area.
No, I fully agree. I think oxidative stress during epididymis transit in patients with, partial obstruction like this, it is significant, and it will be detrimental to sperm. Obviously, we can check. We can also perform, let's say, some people might say, okay, I have this microfluidic, like this is like a magic bullet. Although I feel it's helpful, we need to consider that the oxidative bases that we have during, oxidative stress attack might not be completely eliminated by any microfluidic device. So, we still need to consider the anatomy as you presented beautifully in the talk, and how actually we could get higher quality sperm. But definitely, this is something that needs to keep in our mind to change the approach, not actually insisting on ejaculated sperm if the results are poor, and also taking this conversation with the lab professionals, because they see actually sperm and they see what's going on in the embryo development, etc. That could provide very important feedback for the clinicians.
How do you feel about going ahead and wrapping up, or versus should we finish with our last case, which will add another 5 minutes or so? You're muted, Sandro.
Sorry about that. If it's okay with you, we can go for another 10 minutes. It's not a problem.
Okay, great. Well, thanks for everyone for hanging in there, and my apologies if anyone has to jump off. I know we have clinical things going on in our office this morning, and this is going to be recorded. So if anyone out there in Europe or Asia or South America needs to get on with their day, this will be recorded. So case number 4 is a 43-year-old male with a 34-year-old G0 partner. They had primary infertility for 12 months. He had a history of chlamydia back in 2014. He said it was asymptomatic and was diagnosed with, quote, routine testing. And I said, why did you have routine testing for STDs? And he said, well, I've had over 100 sex partners. So a significant risk factor for obstruction here. He also had what I called post-finasteride syndrome. That's not what he called it, but in early 2020, he had started finasteride for alopecia and had severe and sudden decrease in libido, which was ongoing after stopping the finasteride. And this is a known syndrome in urology, which has no real explanation as far as why this would be permanent. The finasteride is an androgen blocker that helps with hair growth. So he had Still syndrome, which was diagnosed in 2007, which was not an ongoing issue for him, and had no tobacco or alcohol. He had relatively atrophic testes bilaterally, but not severely so. There were 14 cc's, and everything was otherwise normal on his exam. He had 2 semen analyses that were normal volume. They were azospermic on centrifugation, so no sperm seen. His labs indicated he had a very normal testosterone level. FSH was mildly elevated to 10.4. I always say when it's over about 7, that's consistent with spermatogenic failure, spermatogenic defects. So this is more in line with testicular insufficiency or testicular failure than obstruction based on the FSH. His genetic testing was that he had a normal karyotype, a negative Y chromosome microdeletion, and a negative CFTR gene, or a normal CFTR gene rather. So his diagnosis is azospermia. Somewhat unclear if obstructive or non-obstructive because his testis volume and his risk factors for obstruction, although his FSH would suggest he's likely non-obstructive. So this is a polling question. I'll just go through the answers here in an effort to save time. What's the next step here? Would you do medical therapy? That's not indicated because he's already got an elevated FSH and normal testosterone level. Diagnostic TESA or TESI, that's a pretty good option. I was wondering if people would choose that. Direct to micro-TESI, which you'll see is what I decided to do. Medical therapy with Clomid would not be indicated, and cystoscopy could be considered for someone with such a history of STDs, but wouldn't really have any bearing on the outcome here. So the real question is, should we do a diagnostic TESA or TESI to see if he has sperm, or just move straight for the gold standard for a patient with presumptive non-obstructive azospermia, which is what I did. So the plan was for a TESI versus a micro-TESI. If we got in there and there was quickly and easily sperm found, I wouldn't do the full exposure. But what we did was we took one quick sample and we didn't see sperm, and so then I completed the incision for a full micro-TESI incision on his right testicle. and did the full exposure. We found sperm in 6 of 12 biopsy sites in his right testicle. So given this degree of hypospermatogenesis, this is definitely a non-obstructive vasospermia case, although several of the sites demonstrated motile sperm. And I only did the right side because we felt like we had enough sperm for cryopreservation and for IVF. And that way, if they needed a fresh microtesty later, he would have a virgin testis with no scar. And so the sample was banked into 4 vials. And fortunately, the test thaw revealed motile sperm. This did not show up in my lecture anywhere. I think this is an interesting way that I do this. This is not something I've seen anyone else do. So just to put out there how I like to map for a microtesty. This is a relatively complex slide here, but I use a mapping scheme of 4 letters where the first letter is right or left, the second letter is upper or lower, U or L. The third letter would be lateral, central, or medial, LC or M. And then the fourth letter would be superficial or deep. And this correlates to one of these 12 quadrants. So this is showing the testicle kind of clamshelled or bivalved open. So it's kind of turned open like this, where we have the upper and lower here. So you have the upper here and the lower here. And so like quadrant 1 would be RULS. And so I can very quickly, as we're pulling a sample out, I can say, oh, this is from RULS, and then we can map that down. So like the right upper lateral superficial quadrant here, right there, right side, upper side, lateral side, and superficial. So that way we can, when I'm on site 7 and the lab says we just found sperm in site 2, I can go back and say, oh, like where was site 2? And if someone says it was RULS, I know I can go right back to this area of the testicle to look to see if there's more sperm there. And so in this patient, I've shown you with X's where the sperm came from. Sperm were found in the right testis on the medial side in the deep sections in both the upper and the lower poles. So there was one other site where we found sperm up here, but all these others were negative. So we had a great IVF outcome, 7 eggs retrieved, 3 of 7 fertilized. The typical fertilization rate for microtesty sperm is around 50%. So this is a little bit lower than what we would hope for. But fortunately, we had 2 blasts, and these were biopsied for PGTA, and those results are pending. So happy to have blasts at this stage, and sorry that we don't have the final outcome here to share, but an interesting case nonetheless. So if we have just a couple of more minutes to go through our discussion questions here, I'll open up the floor to our faculty.
Yeah, to add to that, we got the results on the PGTA, I think, last night, and we do have a euploid embryo. So the story continues, and we hope for a positive.
Wow, that's awesome.
Yeah, good news. So for Dr. Estevez, Dr. Coward went directly to a microtesting in this case, and he talked about that a little bit, with testicular volume being 14, FSH mildly elevated, and a person who has risk factors for obstruction from a history of STIs. Would you have considered a diagnostic TESI or TESA?
Not really. I think this patient, based on the FSH, which for me is elevated. It's higher than, as Dr. Coward highlighted, over 7.6. We consider the patient having spermatogenic dysfunction. And also the testes, although not very small, more into the lower size. I would consider the case as non-obstructive vasospermia, and my preference in that case would be to go directly to sperm retrieval with the microsurgical approach. So I would do exactly the same in this particular case.
Sandra, do you always do bilateral microtesting, or would you have stopped at the unilateral success like we had, where we did the right side, found enough sperm, and then closed up at that point? What would you have done?
I do unilateral if a case is like yours. I mean, that I discuss with the lab and we are confident with the number of sperm we have. And then, I mean, the other important thing we consider quite a lot is like the female partner ovarian reserve and what we can achieve. This is also a follow-up question I have to Dr. Kaplan, Dr. Peavy, because I mean, patient of 40, we need to have, in many cases, repeat IVF cycles, and then we need actually to have sperm for, I mean, continuing. So we try to overstimulate patients like that, especially when we have severe male factor infertility, and then we go for the antagonist protocol. I mean, with the GnRH trigger, if the patient has any risk of ovarian hyperstimulation. But the idea is that because of severe male factor infertility, as you highlighted, we might get lower fertilization rates as compared to other cases, and also lower blastulation rate. This is very important also to coordinate the female aspects and to, I mean, give the lab more oocytes to actually overcome these difficulties. But I would go for unilateral in cases in which I find enough sperm.
Yes, and I would agree that we try to optimize numbers of eggs retrieved, of course, in alignment with what the female partner has to give. We do the best to get as much as we can so that we can weather the expected diminishing marginal returns as we go through fertilization to blastocyst development to genetic testing. So we are very much aligned in that way. To that point, for Dr. Singh, in this case, when we thawed the sperm, it was motile and we got a great outcome. But what would the lab's response to have been if it's a frozen sample, as it was in this case, and the sperm had not been motile, not having a fresh sample available? Would you have been comfortable proceeding with ICSI with non-motile sperm?
Yes, that would be the, having motile sperm is ideal, and it is a great indication of viability. But just because sperm is not motile does not mean it's completely non-viable. So we would use it at this point. And if we did not get fertilization, that would be our answer, and we would have to treat this patient again. And then we wouldn't use non-motile sperm. But in the beginning, definitely we would use non-motile sperm injected and hope that we would expect even slightly lower fertilization rate than we would have with a TESI motile sperm sample. But I would expect some fertilization.
If I may just ask very quickly to Dr. Singh, in terms of any sort of sperm stimulation or oocyte activation after ICSI in these cases, or you just go straight to the sperm injection?
We would definitely want to try pentaxiphyllin before we would use pentaxiphyllin and see if we can stimulate some motility. And then in the past, I have tried oocyte activation a few times. I have not had very good success with it, in the sense that I do get the oocyte to activate, we can't seem to get it to fertilize normally. So for the first time, I would really just want to try it without oocyte activation and hope the sperm does the job on its own.
This is brings up the point of fresh versus frozen microtesting as well. And we had talked a little bit about this earlier as to when we would consider fresh versus frozen. And so if the patient has a successful microtesting, we find sperm, then the test all shows only non-motile sperm. And then we did decide, and hypothetically, we would go into IVF and inject non-motile sperm, if we had failed fertilization, like a completely failed FERT cycle, that would be one where we've got a left testicle that has never even had a surgery. And so I would then plan on a fresh microtessie in coordination with IVF for a couple like this, that way the non-motile sperm that we inject are more likely to be viable. Well, that concludes our presentation. So I think we have one final concluding slide deck, or do we, Sandro?
Yeah, I just go for the closing remarks, but before I do that, I would like to thank you very much, Dr. Coward, Dr. Copeland, Dr. Peavy, Dr. Singh, for the participation of Atlantic Reproductive Medicine specialists, giving us this beautiful live session and contributing a lot for all participants to increase the knowledge, awareness about male infertility and the importance of the male factor in ART. Thank you very much. I would like to give you a minute to say a few words before I go for my slide deck and concluding remarks.
Yeah, thank you again, Sandro. It's an enormous pleasure and honor for me to participate with Medea, with you, and with our faculty here to share our experiences in our center, where we've developed a very close integration with male reproduction in the IVF center, which we think is the ideal way to provide reproductive care to couples. We hope that this conversation has stimulated some new ways to think about your way of dealing with severe male factor or azoospermic patients. And I look forward to doing this again someday, and for Sandro to see you soon. Thanks again for having us.
Thank you for this opportunity to collaborate.
Thank you. This was great. This was very knowledgeable. I feel like even though these cases were done here, it's great to review it, and it's just great to learn, refresh all the techniques, all the sort of sperm retrieving techniques. It's a very great presentation.
Thank you, everyone.
Thank you very much. So now I move to the concluding remarks. So I would like to thank you very much for being with us today. Also, again, thanking our partners, all the societies sponsoring this meeting. Please remember to complete the post-webinar survey that you receive by email. This is important for you to get your CME certificate, certificate of attendance, and also the diploma that you provide to you later on. So now we had the first session on the Saturday 26th. This session is available online. You can review it if you want. Today we had the second live that will be also available very soon in the e-learning platform. And please join us next week directly from Denmark on the 10th of December for the third and last live section of this year's male infertility preceptorship. Thank you very much for being with us. Take care and goodbye.